Our next session begins now, and we're going to call back to the podium Dr. Sorois. We're making the professor really work at this meeting. We're going to have a series of case presentations and then discussion of each as they go along. Dr. Sorois is going to present a patient who is not diabetic with three-vessel disease.
Thank you, John. So this is just a short presentation of a patient of the fast-track trial. It's a patient of John. He's 55 years old. He's a BMI of 25. He has hypertension, dyslipidemia, type 2 diabetics, and an ejection fraction of 68%. And two slides about the fact that the anatomic syntax score was applied in that trial, just to tell you that each coronary segment has weighing factors related to the physiology, and we are improving that with AI. And then there are lesion characteristics, and you could see we look if it is a total occlusion, trifurcation, bifurcation, autoosteal, severe tortuosity, length, heavy calcification, thrombus, diffuse small dominance, and all these things. And that's the syntax score, which is still alive 15 years later. Now, this is the case. Let me see if, you could see there is bifurcation of the PD. There is calcification all the way. There is a small posterolateral branch. If you look at the LAD, it looks okay, except that you have calcium there. The circumflex is totally occluded, but with the multi-slide CT scan, we could see the distality of the circumflex. If you look at the main stem, the LAD and the proximal diagonal, there's a huge amount of calcium. It's amazing. I think nobody has measured the LPPLA, but I'm sure it's very, very high. When you get so much amount of calcium, it has to be the case. So we applied the syntax score 2020, which has been tested in all these trials. And basically, you have the anatomical syntax score, you have the type of disease, current smoking, age, creatinine clearance, ejection fraction, diabetes, peripheral vascular disease, and COPD. And then you have two formula, probabilistic. This is for the 10 years mortality, but also for the 5 years MACE. If you want to send the patient to surgery, you use the blue parameters. If you want to send the patient to PCI, you use the red parameters. And then you can predict the 5 years mortality, 10 years mortality, and 5 years MACE. And it has been initially published in the Lancet, and then there was a complement because it used this trial to create this probabilistic formula. So just to have a look at the right coronary artery, you can see that the segment 1, 2, 3 is a long lesion, heavy calcification, 9 points. You could see the posterolateral segment 16, heavy calcification, 3 points. You could see that the distality has 1.5 millimeter. We always look in the discussion intercontinental. It was on the Thursday evening with John and many other people. So that's the right coronary artery. You see the segment 4 is 2 points. There is a very severe lesion there. And the 16 is also very severe. The LAD, you have a left main trifurcation. You see the calcium, you see low attenuation in front of the calcium. It's involving the circumflex, involving the right. So it's basically, and there is in between an intermediate, which is here, also calcified. So it's a trifurcation lesion, 11101, heavy calcification, long lesion that gives you 27 points, okay? And if you look at the next, you have also a bifurcation between 6, the LAD proximal, and then mid-LAD and diagonal, that's a 111. AV calcification give you 19 points. And finally, the circumflex, which is a total occlusion. You visualize beyond the lesion. That's the big advantage of the multi-slice CT scan. But the 13, which is in the groove between the left atrium, and the left ventricle, also heavy calcification. And then if you look at the proximal circumflex and the first obtuse marginal, again, bifurcation lesion, heavy calcification, Medina 111. I can tell you, every time you have total occlusion and bifurcation, the interventional cardiologists are in trouble, okay? That's something we have published. By the way, you should read the last paper that I published. You remember last year in New York, I went to the microphone and I say we have looked at the appropriateness of PCI after 10 years, and it was just 17%. If you have a good memory, you remember when I went to the microphone. And I said, I'm unable, with me as a first author, to get that in the literature. So finally, I went to the European Journal of Cardiothoracic Surgery and get published. You should read that. The appropriateness of PCI is just 17% at 10 years, based on the mortality and the syntax score. The 83% should have gone to surgery. And what I did in that paper, I put together the randomized and the registry. Don't forget the pioneer Frederick Moore said, no exclusion. So that's the first time that somebody is looking to the whole things and retrospectively using the syntax score. 17% were appropriate. The rest should have gone to surgery. You should quote that paper.
I promise.
Okay, so I go to the next slide, I think. The syntax score is 75.5, okay? And, oh, sorry, I go back. And this is the FFRCT. As you could see, everything is red. The RCA, the LAD, the diagonal, the circumflex. So there is no difference between the functional syntax score and the anatomic syntax score. And then when we use the syntax score 2, the 10 years mortality should be 19.8 with PCI versus 9.2 for bypass surgery. And the 5 years MACE would be 22% for PCI and 8.9% for bypass surgery. So you would say that the decision was easy, but I think the most interesting point will be what John has done in that case.
So we're trying to make this a very interactive sort of heart team conversation. And I know that we've outnumbered the cardiologists in the crowd, in fairness. I think I saw Bill McKinnon earlier. Is Dr. McKinnon in the room at the moment? Okay, he's a CTO expert, interventionalist. He'll be giving a presentation later. There he is. Bill, any interest in this case? I should preface this by saying Dr. Nicholson is my colleague at Emory, my friend and partner, and also an exceedingly skilled interventionalist.
Well, thanks, John, for inviting me. I feel like the hen that got let out into the wolves. But
Yes, pretty much. So apologies in advance.
no worries. I think for these kind of cases, you know, I think we do 420 CTOs a year at Emory, and you know, we have a success rate of around 93%, and that's all registry recorded. We can do these cases. These cases, I think, are better served by you guys, and I think you see that reflected in our referral patterns. We take these when they're surgical turndowns, is most of the time, and it's not infrequent. And you know, we see a ton of patients that have comorbidities and frailty and other issues that get turned down routinely. So we can do these cases, but I think, you know, it's the argument of long-term outcomes with these kind of complexities, these kind of syntax scores, I think is done. I mean, you know, I think we've come to that realization. I think this is better served by you guys. But, you know, I would argue the other part too is, you know, we're very blessed with John. this patient's going to get all arterial conduits at our center, which, and I agree with everything that was said earlier about, the long-term outcomes because you're bypassing, multiple territories and you're protecting the downstream. But, vein grafts, invariably we end up with CTOs of 80% lesions when you follow these people long-term. Those veins are not going to last forever. And so when they do close, you are going to have an infarct. And so we treat those all the time. And so we end up going through these degenerative vein grafts to do CTOs very frequently of the vessel that was not a CTO before. So if you could give me a scenario where John's going to put all arterial conduits on this, they're going to have long-term patency, we have no competition. I mean, there really isn't. I mean, I think, but that's not always what we see out there. And, and a lot of this is unfair too, because, you guys are the best surgeons, not you, Patrick, but the surgeons on the panel are best surgeons in the world. That's coming from a guy who's in academics now, but was in private practice for years. There was data back in the 80s where they were cathing everybody that went for bypass surgery 1 year afterwards to look at the grafts. And if you looked at 2 institutions in Philadelphia and Cleveland Clinic, it was 97% patency from the Cleveland Clinic with the Lima, and it was 60% at one of the institutions in Philadelphia and 50% at the other. That's physician-driven. And so there's no procedure, in my opinion, in medicine that's more dependent on you guys as the surgeons. Great surgeons get great results, patients do great. Bad surgeons get bad results, patients do terribly. So that's my feeling.
Yeah. Well, you really reiterated the mission statement of our international society, which is to improve the quality of surgical coronary revascularization, and also say it's this particular patient is in his, I think, 60s and had a normal ejection fraction. But, sometimes those very calcified coronaries that you saw come in an 85-year-old patient with an ejection fraction of 30%, and our enthusiasm for doing 5 bypasses is pretty limited. So it's great to have someone who can open a culprit lesion, even if it's a CTO and heavily calcified, and get that patient home. So it's a partnership. It's great to have great interventionalists lead the heart team.
What did you do on this patient? What type of graft?
The first thing I have to say that John didn't have access to the coronary angiography.
Yeah, he did on.
That's the point. I mean, so the first presentation of the patient was multi-slice CT scan. And I have to tell you that there are today 300 sites in the world who have the photo counting. That's a revolution. That's really amazing. I think I will have the chance tomorrow to present that. It's fabulous. I mean, it's a resolution which is far more superior than angiography. So we will see that. But what happens here? So we present the case on Thursday evening, and John sent a cartoon, and he said, I will use a Lima, and then I will prolong I will go to the first diagonal with the Lima, and then I will prolong and go to the LAD, and then I will put the radial artery on the side of the Lima going to the obtuse marginal. And then I will use the Lima extended with the radial artery and going to the PD and the posterolateral of the right. I said, good luck. But he did something different, okay? So he used the Lima. He went quite distal because you remember there was some calcium there. We don't have to have the scenario of Thorsten. And then look at what he did. He put the radial, which is connected to the Lima, and then go to the obtuse marginal and the diagonal. And then indeed, he followed his ID to do the Lima with the extension of the radial to the PD and the posterolateral. Having seen that cartoon, I say, good luck. But we control everybody. So 30 days later, everybody has a second multi-slice CT scan. So not only is doing this, but is doing nice assessment post-surgery. I will not go into detail, but you could see the arrow indicating where the flow has been measured on these Limas. Sometimes the probe is upside down, so you have to pay attention about the signal. Here the probe is put upside down and also there. But all these bypass at the end of surgery were patent. This is all off pump. This is all off pump. Okay, now the moment of truth. Okay, what happens? So here you have a global view. You have indeed the lima going quite distally to the LAD. And I will go to this radial, which is patent, connected to the lima, and go to the diagonal and to the obtuse marginal. And if you look at the lima, prolonged by the radial artery, he gets on one of the branch of the PD, and he went on this posterolateral, 1.3, 1.5 millimeter diameter. Here you got a more dynamic way to look at that. You can see by yourself the trajectories of the LAD and the trajectories of the lima with the prolongation by the radial. And that's a view of this connection of the lima with this radial artery who goes on one hand to 9, the diagonal, and on the other hand on the 12A. So you could judge that by dynamically, if you're not convinced by the volume rendering pictures. You look in all these, the view, lima on LAD, lima radial artery, diagonal 1, obtuse marginal. And then at the end of the day, we said, is the revascularization complete? No, it's not complete. He didn't do the distal circumflex because it's in the groove there and it's total occlusion and well perfused. But in the syntax score, you get a residual 8.5. So you went from 75 to 8.5, yeah? And tomorrow I will show you how we do that quantitatively now.
Yeah.
We abandon the fixed score of the syntax score, and individually we give point based on the flow. I'll show that tomorrow. So this is what happens. He had a 75.5% anatomical syntax score. It's not the top in the world. I had one times an 84, okay? But from all the patients that I have seen, it's the number 2, okay? And then the functional syntax score was the same, yeah, because everything was red on the FFR CT, okay? And he brought back that to 8.1. So I really believe what Mario has said. As a matter of fact, if you check very carefully the literature many years ago, and that was the legacy of Frederick Moore, a giant, who said, I don't care about this episode of atrial fibrillation, of a drain, of this and that. If 10 years later you still have to do an 18-hole golf, that's okay. That's medicine. Thank you.
Let me take, before we introduce the next speaker, 5 more minutes, and I love what Dr. Nicholson said before, because we really imagine this one as an interactive. Reality is that you did a fantastic job, Dr. Pascas, like K-graft of a radial off of a lima to a diagonal OM, Rita extended radial to... Reality is this is like less than 1%. Let's admit. Reality is that, as Dr. Nicholson said, 58 years old patients, I think, we said like late 50, maybe early 60, 99% of the surgeon, Europe and United States would have give only one bypass to that right. No, very few of us, even in this room, would have given 2 bypass to that right. A 1.3 LPBA, and they would have put a vein. How many of you would have put a vein? And I know that, like, but in honesty, how many would have put a vein on that right? And I can tell you, I think that 90% plus of the surgeon, even if the patient is the 50, would have put a vein in that right, heavily calcified, really bad target. The second of the 2 targets looks small. And that circumflex probably, hopefully, surgeon would have done a lima to the LAD, a radial to that OM, and a vein to the right. And that's what the patient would have gone home. And if he was in a good center, because a lot of people would have just said, oh, that CTO of the OM, I'm not sure, I don't like it. Let's put a vein, I feel more comfortable. And what we end up is that the patients get a lima to LED and 2 veins, circumflex and OM, exactly what we were going back to the previous point. Dr. Sarois.
I think I will need your help tomorrow, because we have been working very hard with the Minneapolis centers and Dr. DiBianco. And we have done a lot of sheep with bypass between the descending aorta and the LED ligated. And this bypass is made of quote-unquote biodegradable supramolecule. And with Renou-Vermani, and we have published that, we have shown that there is endothelial cell, von Willebrand factor positive in this graft all the way. Scanning electron microscopy, transmission electron microscopy, and I really need the support of the surgeon, because the day you have on the shelf something scalable, and patient has been done in South America, but patient has been done with that kind of graft, but the industry hesitated. And there's no surgeon there to say, go for it. And I'm not strong enough to say go for it. So I need your support. I'll show that tomorrow.
We look forward to that.
Okay, in terms of time, I will skip my presentation of the triple vessel disease, and we will go directly with Dr. Jennifer Lawton talking about a very hot topic in surgery and PCI, isolated left main, non-diabetic, 60 years old. Dr. Jennifer Lawton. Thank you for this disrupting in the flow, but please.
Thank you for the kind invitation. My presentation is a little bit different. I'm going to talk about left main in a 60-year-old with no diabetes. I have no financial disclosures. I'm a cardiac surgeon. I like arterial grafting, and my comments will be my own opinions. Brief outline, I'm going to talk about how left main disease is difficult to tease out from multivessel disease because patients often have both. I'll show you the randomized controlled trials on left main disease and how there is equipoise for treatment. And we spoke a little bit about that earlier this morning about how they're highly selected patients. The current evidence and how a heart team approach as we have today is vital. So this is the patient. There's a 90% distal left main stenosis, normal right coronary artery. You can also make out in the left injection the descending aorta, and in the right injection, there's quite a bit of calcium in the ascending and descending aorta. And I put what I did in this case on the slide, but I should have probably hidden it. So in this patient, isolated left main, I think complex left main, and then normal right. So this patient got because of the calcium in the ascending aorta and the descending, a no-touch aorta, beating heart, lima to the LAD, and a radial T to that OM. So I'm going to talk a little bit about, this is a slide that you're not meant to read, but it's just me summarizing all the randomized controlled trials for left main disease. You can see the trial name in the first column, the inclusion criteria, the exclusion criteria, patient population, primary outcome, secondary outcome, and then some of my own notes. So focus on the second column, which is the inclusion criteria, and you can see the red circles. So in every single one of these trials, PCI versus CABG, both the cardiologist and the surgeon had to have equipoise that either treatment modality would be appropriate for the patient. So you can see there are low syntax scores, and they tended to be patients that are in their mid-60s and low risk, if you will. If you look at the primary outcome, it's the same in most trials, no difference between the primary outcome, which is a composite of multiple things that we call MACE. But if you look at the Noble trial, you can see repeat revascularization was included in the primary outcome, which made CABG better. We heard a little bit about the importance of repeat revascularization this morning. This is nicely summarized in this meta-analysis of 5 of the randomized controlled trials of almost 5,000 patients. And you can see on the first line, the outcome of all-cause mortality, again, at 30 days, 1 year, and 5 years, not different between groups. The second line, myocardial infarction, largely favors CABG in the long term at 5 years, which we also heard a little bit more of this morning. Stroke favors PCI due to the risk of stroke with CABG. And in the last row, repeat revascularization significantly favors CABG at 1 year and 5 years. So if we look at the current US guidelines, this is an algorithm for patients with stable ischemic heart disease, which I assumed this patient would have, a 60-year-old isolated left main. And then we look at the red circle, which includes those patients with isolated left main disease. So we're not talking about diabetic patients. We're not talking about low ejection fraction patients, patients with unstable angina, patients with cardiomyopathy. And in the red circle, if patients have complex left main disease, we know you can never go wrong with CABG. It's a class 1 recommendation to have CABG for left main disease, whether that be low syntax score or low complexity or high complexity. And you can see it's green, class 1 recommendation, which means benefit greatly outweighs risk. Over on the right side, in the middle of the slide, you can see there is a 2A recommendation for PCI in low complexity. And then if they're not a CABG candidate, a heart team discussion should occur. And these are just the US guidelines listed here. The class 1 recommendation, benefit greatly outweighs risk with randomized data. Patients with stable ischemic heart disease and significant left main stenosis, CABG is recommended to improve survival. And then the 2A recommendation in selected patients with significant left main stenosis for whom PCI can provide equivalent revascularization. Again, equipoise between the 2 treatment modalities. PCI may be reasonable to improve survival. And then an additional recommendation with class 1 recommendation, again, benefit greatly outweighs risk. In patients who require revascularization for significant left main disease, high complexity disease, it is recommended to choose CABG over PCI to improve survival. The European guidelines from 2018 structure it slightly differently, largely based on complexity of coronary artery disease. Again, left main is often associated with complex multivessel disease, but you can see for CABG, class 1 recommendation for any syntax score, whether that be low, medium, or high. You can never go wrong with that. Benefit greatly outweighs risk. However, PCI, there is a class 1 recommendation in the European recommendations for low complexity syntax score, and then a 2A for intermediate, and a 3. A 3 recommendation means no benefit or harm. This is another summary slide that I made. So on the far left, it's important to remember the patient's shared decision-making and the patient's wishes, and then also the importance of a heart team. But to improve survival with left main disease, CABG class 1 recommendation. There's the 2A for PCI for non-complex disease. If we look at these left main pictures over on the top right here, you can see this is complex trifurcational disease. However, in the XL trial, as I mentioned, there were highly selected patients. Only 10% of patients had such complex left main lesions. And then we know that repeat revascularization in PCI was significantly higher in this trial versus CABG with distal left main or complex disease. You can see how these distal left main lesions could be difficult to address with stenting. And then with patients that had ostial or mid left main disease, as you know, the mortality was no different. So to summarize at the top, low complexity disease, isolated left main disease, proximal or mid shaft, patients that will be DAPT compliant because we know the importance of remaining on DAPT with a left main stent, and then perhaps those patients that are high risk or frail. CABG in high complexity, although as I told you, it's a class 1 recommendation for any complexity with left main disease for CABG. Distal, trifurcational, or bifurcational lesions. If the calcification will be difficult to stent, the stent expansion is limited, and only our cardiology colleagues can tell us that. If there's a DAPT contraindication, and sometimes if the patient is older and less likely to benefit from the longer term benefits to repeat revascularization with CABG. So it's not us versus them. This is our surgical team at Johns Hopkins and our interventional cardiologists. It is us with them. In other words, together we can bring the best treatment for each patient with a heart team discussion. And I added some additional angios to highlight that. This is a patient with a very complex distal left main and occlusion of the proximal LAD, in addition to diffuse complex disease. This patient received, I gave a REMA, a LEMA, and a radial to completely revascularize this patient. These are two patients you can see on the left, complex distal left main and occlusion of the LAD, and another patient with occlusion of the circumflex with distal left main disease. Both of these patients went to CABG, as you could imagine. This patient has a complex, what looks like distal left main disease, but if you look carefully, the lateral wall is supplied by these multiple diagonals, and there's complex left anterior descending disease. And turns out the patient had an anomalous circ from the right, and then the posterior lateral was occluded. This patient actually had a heart team discussion, was offered coronary artery bypass grafting, and chose high-risk stenting. So the patient's personal wishes were to not have surgery. So again, the importance of a heart team discussion. Having a heart team discussion for complex patients is also a Class 1 recommendation in the US guidelines. And then I have a person here on a little balancing act. It does also depend on the patient's wishes and shared decision-making. There's a Class 1 recommendation for that also. And so to summarize left main disease, I was looking at these slides in my hotel room, and my husband said, "What is that picture in the middle there?" And that's a coronary artery with a stent completely occluded. And he found that grotesque, but unfortunately, we deal with that a lot. Left main disease is a high-risk subset. A heart team discussion is important, as I mentioned. We know that isolated left main disease was only in about 15% of the randomized control patients. Three-vessel disease was in 20% of them. And then largely the patients in the randomized controlled trial were mean age of 66, low and intermediate complexity. And again, clinicians had equipoise for both treatment options. And so we do need more time, longer follow-up, and more patients and more women, as Dr. Gaudino mentioned. Thank you so much for your attention.
Thank you. Please stay. Couple of technical questions, and we would love also to have, if someone wants, please feel free to take the microphone. Well, from a graft choice, left main, give us a little bit of how do you decide when you have a lesion that is a long left main, proximal portion, perfect continuation between LAD and circumflex, we know disease there. Now you are landing your LITA to the LAD. Number one, should you put a second vessel on that circumflex? And I think the answer is yes. And what type of conduit do you choose? Do you ever think that if you choose a radial and you attach to the aorta, you can have a competitive flow from the vessels? And how do you decide what is your graft configuration?
Mm-hmm. That's a great question. And we're not usually privy to the angiogram a month or 2 years later in those patients. And I suspect one of the grafts does go down if there's competitive flow. But my hope is always to start with all arterial grafting. So depending on the patient, I'd probably do a LEMA to the LAD and put a radial on the obtuse marginal. Hopefully there's some other disease there somewhere that you can hope that they stay open, but that's what I would do.
Yeah.
See, I think that a key concept is to avoid asymmetric competitive flow within a composite arterial graft. So what you did a LEMA LAD, a radial off the LEMA to the circumflex. They share one inflow, two outflows, but they face the same competitive flow. So there's no asymmetry in competitive flow. I suspect that your two grafts will stay open indefinitely in that patient.
Yeah.
Now, if you had put the radial from the aorta, then the potential exists for competitive flow between the radial and the LEMA. But that doesn't exist if the radial comes off the LEMA. I will tell you, when you were showing that angiogram of the patient, the first patient, I thought you were showing my patient from Monday because the angiogram was identical, and even the pattern of coronary artery branching was identical. It was a little spooky, and I did exactly the same thing. LEMA LAD radial off it to the OM, done. And my hope is that, like yours, mine will stay open.
John, can we just ask the audience quickly out of interest? So if you have a patient with isolated left main, either ostial or mid-shaft, not involving into the proximal coronaries, the question is who would do a single graft, limit to the LAD, and then I'll ask who would do 2 grafts. So for a single graft?
And I know lots of surgeons would, and this is not uncommon.
Yeah. Yep. And how many would do 2 grafts?
Now,
Like, so-
how many of those with 2 grafts would take that graft off the aorta? Most probably, right? Yeah, which is I think that is the controversy exists between, in my mind, between 1 graft versus 2 grafts with the second graft coming from the aorta, because again, that introduces the possibility of asymmetry of competitive flow, or you've increased the competitive flow against your mammary. But most of us believe that mammary will stay open because the outflow is so good. And I think most of the time we're right. It probably works well all those different ways.
Dr. Saroy.
Yeah, the question of these competitive flow is very, very complex. I mean, I don't think that we will resolve that very quickly, but we are working very hard on that. Fortunately, with the data of John, where you have the flow at the time of surgery, and then when we do the multi-slice CT scan 30 days later, we are making progress, because I think at a certain point, the multi-slice CT scan will be able to give you some information about the competitive flow, which is a very big issue. And then what we try also is to predict that in advance. It's not ready tomorrow, but I think at some point it will be available.
And I think that one day we'll have, AI-derived algorithms from preoperative CCTA that will give you a profile, a menu of possible grafting options and what the anticipated competitive flow would be in each limb of these potential grafts or purported grafts. Dr. Balatan.
Please.
Yes, I think that there is not enough data. I was one of the raising that sometimes I put just LAD and a left main disease. I think there is not enough data to support both theory. And I think that, and I do it, and I saw that in London, Canada, they do it for many years already. If there is a real ostial or mid-shaft left main, and all the other area of the vessel are perfect, LAD should be the new left main of these patients. And we do it not a lot because there are not too many patients with perfect circumflex and perfect LAD, but if such a patient is coming, I'm doing just LAD.
And one of my mentors did that habitually and seemed to get away with it for decades. So it's not always wrong. It might be always right.
Vipin, please.
Thank you. So that was a great presentation, Dr. Lawton. In my hospital, we would have a heart team discussion. Surgeons would offer surgery to these patients. Cardiologists would offer stents. And about a quarter of the patients would choose to go for stents, or maybe more than 25% would actually go for stents. So that's real life what happens in the UK. Number one. Number two, I have a question for John. If this particular patient came for surgery, very likely I would use 2 mammaries, in situ grafts, a lima to the OM or to the LAD and the REMA to the other one. I just want to pick your brains. What happens in competitive flow in those cases? I've never given a thought to it. Patients do well.
Yeah, I mean, I think you could use double mammary grafts in this situation. And that it could be obviously multiple ways you could do that. You could do it with 2 inflows, dedicating either one to the LAD and the other to the circumflex. You could do it as a composite graft. You could take a free graft from the aorta, and we could probably have a show of hands, and someone would do each one of those.
No, but what happens to the competitive flow then? Do we have to worry about competitive flow if it is inflow in situ mammaries to the coronary arteries?
I think that competitive flow is always a consideration. So, but somehow I would fear less competitive flow between double mammaries than I would between an aortocoronary graft.
That's exactly, that's what Mario.
So I don't think the radial was the right choice in that case, and I'm sorry. Jennifer. You know, I love you, but sometimes we disagree. I think the radial is in the hierarchy of arterial conduits. The radial and the GIA are the conduits that are more likely to fail because of competitive flow. It's an histological reason. The thick arterial wall of the radial artery does require high flow because the high flow leads to higher production of nitric oxide that keep the radial artery open. So if you put the radial artery in a situation of low flow, it's most likely to fail because of spasm. We largely underestimate the prevalence of a failure due to competitive flow because patients are asymptomatic. They fail. The reason why the graft fails is that it's not needed. But when you do per protocol angiography, you do find a sizable percentage. So this is a concern. I think when you are worried about competitive flow, the mammary artery is a better choice. So I am with VP, and I would have used two mammary, and probably even two mammary in a Y configuration.
In a Y.
But I don't think the radial artery is a great choice when you are worried about competitive flow.
Yeah. Thank you. Thank
So
you.
here we have one of the world's foremost proponents of the radial artery now advocating for the Rita. So mark the calendar.
Please.
Quick question about intraoperative use of flow probes and competitive flow and potential spasm resolving. So as you're going through these complex situations with sequential grafts and Y graft type configurations and stuff, I presume you're evaluating as you go each graft potentially with it, and you get to the end, and I find oftentimes you have to wait 10 minutes or something for things to really settle out. But how often have you encountered a situation where you felt that you made the wrong decision, you now have significant competitive flow things, and you've now changed your graft? You go back and put your inflow off the aorta or do something. I find that to be a very difficult situation if I have to think about that. I'm just wondering how you all...
I've done that once that I can remember offhand, and it was a matter of a radial artery graft off a Lita to the circumflex, and it seemed that all the steel was going down the circumflex. And I clipped the graft off the Lita and put it on the aorta with a heartstring, and now the Lita flow is much improved. Of course, you do a soft bulldog test first. If you occlude that lateral wall vessel and now the flow is abundant to the LAD, well, that's a pretty good sign. You certainly don't want to sacrifice the LAD. But that was not the case in this scenario. This one that I said, Jennifer's case and mine seemed weirdly identical in the same week. And I measured the flow above and below the takeoff of the radial graft, and the flow was like 85 upstream and 45 downstream. So it was split between the circumflex, which was a big vessel, and the LAD, and I thought that was just fine. You know, so far I haven't had a phone call. It's been less than a week, but you know.
But I think that what Mario said, and I will do exactly the same. Y graft with a mammary, and I think that competitive flow, when you are worried about if you have approximately or the distribution of flow in a competition is less, particularly because the vessels are similar caliber, the mammaries are similar caliber, and you can have a better distribution with an inflow. I will be almost more worried to put a Rita in situ to that circumflex and a Lima to the LAD for the worries that you can have competition if you don't have enough disease between them. Please.
I would like to remind the audience of this presentation by the Chinese surgeon last year in New York, you know, the guy working in Wuhan who do 3,000 bypass surgery per year. And he present 1,000 cases with FFR before surgery. And he came to a conclusion which was very interesting, is that Lima and saphenous vein graft, if you go below 0.8 for an FFR, it's fine in terms of patency. But for the radial, the threshold was much lower. So the patency of the radial requests an FFR of 67. That's much lower than 0.8. And I think in some way it makes sense, yeah?
Yeah, I'm sorry.
Let's move
Very
on
nice.
to the next presentation. Great discussion. I'm happy to introduce my partner and colleague from Emory University, Bill Nicholson. He's in charge of our complex coronary intervention program and has a particular interest and skill and experience in managing chronic total occlusion. So I thought it would be great to have him come and educate us about what he does with these magical catheters and the kinds of results that are capable.
Well, it's really a privilege to be invited, and thanks so much, John. So I'm going to give you some perspective of what we can do. Now, coming here and listening to everybody talk, I go home thinking maybe we shouldn't do any of this and everybody should get bypass surgery, but that's okay. So, but this is an interesting case. I'm going to talk a little bit about the case, but then I want to just show you some different techniques that we use and sort of the data we have behind it. But complex case here with patients on Eliquis for paroxysmal AFib, multiple comorbidities, complex occlusion, had a CTO of the right, that we took care of after the patient was turned down surgically, which would be a great talk. I'd love to hear sometime who you guys turn down and who you don't turn down, and I'd love to hear who has poor targets and who has good targets and how you tell. So and I think your CT scanning would be really nice to apply to that, because we can't figure it out. So when we send a patient to get evaluated, somebody will turn it down for X, Y, and Z, and then somebody will turn it down and say it's a bad target, and which it's hard for us to understand exactly what happens on all these. But the complex CTO here, you can see it's got proximal cap heavily calcified. It's not a terribly long lesion, but it's got some ambiguity to the proximal cap as well. You can see this was part of this patient was enrolled in the Picante trial, which is an interesting trial. It's a competitive device coming out against Impella by a company called Cardian. And in full disclosure, I'm the national PI for that, but that's the trial that this patient's in. We had fixed the right. You can see with the LAD, just to give you an idea of how complex we can get with these things. So this is very calcified. We leverage the subintimal space a lot, so we do a lot of dissection reentry. We were only able to get a wire into the subintimal space. We couldn't get past the calcium, so we cut the rotowire off and the tip off so we can wedge it in there, and then we wrote it into the subintimal space. So you can see we're rotating out of the vessel into the subintimal space intentionally on this short wire. It's safe, we do it. Not everybody does it everywhere, but we get into the subintimal space, and then we use a lot of knuckling. So this is dissection, so this is going down intentionally between the media and the adventitia. It drives us downstream. It's a very safe way to travel in the vessels. The adventitia, as you guys all know, is extremely rubbery. It almost never gives or perfs, and so we can use that to kind of blunt dissect our way down. Then we use a device called a Stingray balloon. This is a reentry, a purpose-built reentry catheter. So we're in the subintimal space. We went true lumen, false lumen. We need to get back into the true lumen. So this device basically, there's an animation. One of my very close friends, Chad Kugler, invented this. I have a device we sold to Teleflex. It's going to take this off the market in a year or two. But you can see the idea is it's a self-orienting balloon. It's got two ports. It has one port that will exit and go up into the adventitia. It has another port that will come down and go back into the true lumen. Takes some learning curve to get good at this, but the skill level you can develop over time and understand how to get the correct port and how to get back into the correct lumen. And we were able to penetrate back into the true lumen there. So now you've gone true lumen, subintimal, true lumen. And you could say, what's the efficacy of that? This is just an example. There's the balloon. We've fenestrate this with a very sharp wire. It allows us to get a jacketed wire to go in downstream. So we're true lumen up here, false lumen all through here, back into true lumen here. There's data out there done by some real close friends from the UK who looked at the efficacy of this. Does it matter if you stent the subintimal space versus to stent the adventitia? Do they endothelialize? And it's a really good trial. It's very rare that you can have this, but they had angiographic and OCT follow-up of like 97% of the patients. So brought them back and actually did OCT. They do endothelialize the struts, whether you're in a subintimal space or not. Interestingly enough, if you look by imaging, we're wrong a good percent of the time. When we think we went subintimal and came back in, we were true the whole time. Times we think we're true the whole time where you've gone subintimal and re-entered. But the long story short, there's not a statistically significant difference between using the subintimal space to do your revascularization versus using the true lumen. And so that's what you end up with here. We stented that. You end up with what was probably a poor target downstream for you guys. I don't know, but I don't get to operate, so it's okay. But just to show you, and that's the CTO of the right that we had done before. We do a lot of retrograde too, so this is really interesting. So this is a left dominant circumflex with a CTO of the LAD. You can see, again, it's a difficult one for us to penetrate antegrade, but we've got these nice septals coming off the LAD. We use those a lot, so if you go downstream into the circumflex, you'll shoot the septals, you'll see they connect up to the LAD. We're able to wire through that, so you'll see a wire come down, and we'll go through those septals, track that wire all the way up to the LAD, and that's going to hit the LAD and pop down the LAD, which is the world's greatest target for us to be able to stick or for us to be able to wire towards. And you can see it's just parallel wiring here, so we've got a wire marking in true lumen. I can be very aggressive with sharp wires at this point because I know what's right and I know what's wrong because I've got a wire there marking where we're going, and I'll show you that. But just eventually we hit the right spot here, and it's the wrong spot, wrong spot, wrong spot. And then this one hits you see the resistance we meet there, you can see the wire kind of buckle and then penetrate through the cap, and then that's off and down to the true LAD. I'll show you just one last one here. This is interesting too. We see this in about 15% of mid-proximal LAD occlusions, well, mid-LADs, but you see septal to septal connections not infrequently. These are, I do a ton of live cases, and these always look really good on TV because it looks kind of magical, but they're actually quite easy. You can get down into this septal, and you can see it's filling the distal LAD, and so we have wires now that are so forgiving that we're able to make it do these kind of crazy tracking courses, and you can see that's tracking that septal. It's going to do a U-turn, head back up towards the LAD, and kind of in the zone there. You'll see this tracks further. It's pretty remarkable what can be done. There's really nothing we can't do. I think there's a bigger question of what we should do, but there's not much we can't do. So we come backwards here. We do what we call reverse cart, where we're subintimal both directions. We balloon all that subintimal space, make the wires connect, externalize the wires out, and then you can treat at the end. So there is some data on LAD, CTO, PCI. It's single center, but it's a fairly large number of 230 plus patients. This is from Cal Aliswad's work out in Michigan, but very high success rates, not surprising. He's a great operator. Good survival rates, as opposed to what Dr. Steroids and some of the other folks said. They did see an EF improvement, but again, it's not corrected for medical therapy as well. So, but it's something we can do. We offer, I think a robotic lima, if I was a young guy or a gal coming out of training as a surgeon, you'd have to put a gun to my head to not have me learn how to do a robotic lima to the LAD. It's extremely attractive to the cardiologist. Me being a CTO operator back in Pennsylvania, I was doing about 220, 230 CTOs a year on my own. I was routinely sending 100 plus patients for robotic limas. So it's an extremely attractive therapy for us. When you talk about where we stink at stuff, we stink at the osteal circumflex that's calcified. So, that's an area where if you guys had arterial conduits to offer to that area, it's extremely attractive to us. And so it's really fun with John and Mike Halkos and some of the other colleagues we have back at Emory. I think it truly is a hard team. I think there's a lot of combined effort that goes into making decisions, and there's a lot that both have to offer. So, super. Great. Thanks.
I want to ask you some questions. So the first one is let's say 70 years old, a female, was going to have some type of surgery. The clearance of the surgery was they doubted something in the cardiac space, come out CTO of the LAD. No symptoms, overall good patient. If she comes to you for a potential PCI CTO, of the LAD, when you consent her, what do you tell her about your 5 years results of your work what is in the current era?
Yeah, I think it's a fair question because I don't think in a CTO world we don't have that answer. Okay, so we have 2-year data, and 2-year data would say that it's somewhere around 3 to 4% TVR, failure rate. So I think the question comes up with the DAP therapy and things like that, in those situations. If it's a lot of these patients with CTOs, it's always, my dad was one of my partners back in Pennsylvania, and, he's a big advocate of what I was doing. He's an interventionalist, and he used to always say these people are well revascularized, just leave them alone, they'll do fine. I was like, Dad, I'm trying to build a program. But, I think he's right. They do well with surgery. DAP-wise, we've changed completely. So for ACS, STEMI, non-STEMI, it's a year. For everything else, it's a month. So left main, CTO, complex PCI, 1 month of DAP.
Even a CTO PCI, you do 1 month of it?
Absolutely.
Interesting.
1 month.
Yeah.
What about left main, Bill? What's the present feeling about DAPT for the left main stents?
I think if you have, a lot of it's a feel thing, okay? So like if you have a complex, true bifurcation, calcified, you know, we do everything, you know, image guided, but you maybe don't meet your metric on the circumflex, you'd maybe look at 6 months. If it's standard, you know, shaft osteo left main, it's pretty straightforward kind of stuff. I mean, if you pre-treat the calcium, I mean, I'm very comfortable with a month.
1 month.
Probably 2 weeks.
Dr. Srois.
Yeah, I think I'm impressed by the fact that in Europe, in the big trial on PCI that we are conducting, 32% have a CCTA before going to the cath lab. And I'm surprised by the fact that angiography is a quite poor tool to see the calcium. You know, you suspect, but no more than that. But when the interventional cardiologists see the CCTA and the extent of calcium, I'm surprised by the fact that they back up from PCI and say, because you have seen the pictures of the case of John, the calcium is very, very proximal, and the distality is most of the time nice. You don't see calcium in the PD massively or in the, but the way to go there can be terrible. And although the lithotripsy is doing good progress, and now we have the lithotripsy without balloon, which is going to be really something important for us, but I think that the amount of calcium that you see on CCTA is becoming, for us at least in Galway, a deterrent for PCI.
I'd say the amount of calcium in general has just been probably one of the more phenomenal increases that I've seen in the last 10 years. I mean, it is, I don't care how good you are at PCI, it is still an impediment to optimal results. And we battle it, and like was said, you know, IVL's changed some of that. This Javelin catheter that's got no balloon, just IVL on it's going to help, but we still struggle with calcium. There's no question.
And we do too. Dr. Lawton.
Excellent videos. Wow, what you can put a wire through those collaterals. That is amazing to me as a surgeon and frightening. Could you talk a little bit about your management of the septals? A couple of those you had, you know, almost a full metal jacket of LED. How do you manage the septals?
Yeah, it's a good question. So, you know, I'm not saying that this is the upfront best thing. I mean, if you put a leam on there, you're going to preserve your septals. Septals are kind of like cockroaches. They're hard to kill. Like, I mean, they come back. I mean, we you know, even when you do septal ablations, they come back. They've covered stented them in the past to try to cause septal infarcts, and they survive and they grow. So, like, I spend my nights worrying about things, but I don't worry too much about septals.
I love that.
Yeah. Look,
One exception I would say to that is, and this is something that I don't think it's talked about enough in our interventional community. If you have to rotablade a Prox LAD, particularly very complex, that you're going to do extended rotablator with a CTO of the right, and you compromise those septals because you're going to stun 2 myocardial distributions, those patients can get sick. And so, like, that's a different, if the right is a CTO, it's a different story.
Mm-hmm. Can I ask the audience, please, how many surgeons have operated on an isolated LAD in the last 6 months? And can you keep your hand up if you did them robotically? So probably about half and half.
No, I think.
But it's a good point. I think that the fact, and you were citing that, the fact that you have a minimal invasive program within your institution, robotically or non-robotic, thoracotomy, mid-cavity, whatever you like it, but can enhance the treatment of certain patients. And if you don't have a minimal invasive approach, like your interventional cardiologist is less keen to give you a sternotomy limato LED, even if he knows that might be a better option, but you don't get those patients.
It's extremely attractive. I mean, I think if I was young coming out, I don't know how you don't learn it as a young surgeon.
The last comment, and I see some industry and partner in industry here in this room. I mean, I just want to point it out how many amazing tools you guys have for re-entry of the plaque. I mean, we are here begging for more tools in the world of coronaries. I just put it out there.
Yeah, we clearly have toy envy.
Yeah, toy envy. Exactly. I like it.
Pleasure. Thank you so much.
No, you go.
Super. So our next case is an anomalous right coronary artery in a 40-year-old. So we're switching from coronary artery disease of the atherosclerotic variety to coronary syndromes of congenital origin or anomalous anatomic origin. Dr. Lau from Cornell.
Good morning. Thank you for the opportunity to present this case here. It's tough to follow all of the talks that we've heard so far. I feel like this is much more straightforward, but I'll give it a shot. I have no disclosures, and again, this is a patient with an anomalous right coronary artery. She's a 39-year-old female, no real past medical history, but she presented with some intermittent stabbing chest pain that relieved with rest. And she also had progressively worsening exercise tolerance, shortness of breath, and some dizziness on exertion. Interestingly, she always also felt that as a young child, she always felt weaker than all of the other kids and couldn't participate as much in the physical education and activities. So on her stress echo, she had normal LV and RV size and function and valve function by Doppler. And however, she had below average exercise capacity for her age. And on the EKG portion, she had evidence, equivocal evidence of ischemia, but there were regional wall motion abnormalities on stress with inferior and inferior septal hypokinesis. And the exam was terminated early because of shortness of breath. This is her cardiac CT or coronary CT. Here you can see the anomalous right coronary artery coming off from the left sinus of Valsalva. And it has an acute angle takeoff, slit-like orifice, some osteostenosis, and it has an intramural and interarterial course between the aorta and pulmonary artery, and the intramural segment measures about 7 millimeters. So this sort of has all of the classic signs of what would be a symptomatic anomalous coronary. So the first question is whether we should operate on her at all. I think that's pretty clear. She's young, she's low risk for surgery, and she's symptomatic with signs of ischemia. She meets all of the criteria to proceed with some type of procedure. The options, at least surgically, are a coronary unroofing, translocation, and with division and movement of the right coronary to the right coronary sinus. There's a neo-ostium creation where you can leave the intramural course where it is and create a new ostium in the correct sinus, or there's coronary bypass with or without ligation. So all of these are viable options. Admittedly, I have performed or I have tried unroofing on some patients, and if that doesn't go well, then convert to either translocation or ligation. It's pretty rare that you'd have to do the neo-ostium creation, and it's more required sometimes when the intramural course goes behind the commissure, and you can either take down the commissure and later put it back up, or you can do this neo-ostium creation. In our case, we did the unroofing, and here's a picture of the final result. And here's some video for what we did. So this part you don't have to do, but we sometimes like to expose the coronary from the outside. So we dissect between the aorta and the pulmonary artery. Part of this is so that, in this case, we actually measured the flow because we were interested, but part of the point in doing this is to see where exactly you need to stop when you're doing the unroofing, because we don't like to make a hole to the other side, although I do work with some congenital surgeons that say they do make a hole on purpose because it's the only way they can convince their cardiologist that they did a complete unroofing. So here's where we're starting to do it. We did this one with a knife. Sometimes you can do it with pot scissors as well. And sometimes this tissue can be pretty thick and difficult to cut through. So we use a baby right angle to make some space and make our incision. And we try to do this pretty slowly. This is edited video, but this took us a lot longer than this looks. And part of it is because we really don't want to cut through to the other side. So here is our final cut for the unroofing, and it's a pretty short segment that you need to cut through. Like I said, it was only 7 millimeters on the CT, and sometimes you have to wonder, will such a small unroofing actually work? But you can sort of see here that once you get to the correct area, you can actually see the coronary coming out at less of an angle, but more outward. And if you put the right angle in, you can see that the whole intramural segment is opened. After we do the unroofing part of it, we usually put a couple of 7/0 proline sutures to both marsupialize the edge back. In this case, the tissue was pretty thick, so we took a second throw with the suture to really try to pull that thickened part back. You can resect some of it if you think you need to, but then you also run the risk of creating a hole on the side of it. So this is one way to do it, although sometimes when a simple suture can perform enough of a marsupialization, so you don't have to have a little bit of the distortion that you can see when you do it like this. But in this case, we thought that it was helpful to really pull back the edge of the unroofed segment. Putting these stitches is also useful, and I especially try to do it on the edge, the ending edge of it, because just in case you made a hole that you didn't miss, you don't want to have to reclamp if you can avoid it. So I always try to put at least a couple of sutures on the distal edge of it to make sure that any opening there is sealed. There's not a lot of data on the results of unroofing, but most of them are generally pretty good with almost no mortalities, at least in what's reported. So it's a very nice way to do these cases. We've also written a little bit about other ways to do it, including with bypass with or without the ligation. But in those cases, it's usually if a technique that preserves the native coronary circulation is not an option, then we would bypass it as sort of almost a last resort. So in this patient, on outpatient follow-up, she had no chest pain, no shortness of breath, dizziness or lightheadedness, palpitations, or syncope. She no longer felt the burning sensation in her chest. And the best part was she said she could actually feel that she had better oxygen and blood flow to her heart. So I'll end it there. Thank you for your attention.
Super. Chris, thank you for that. I think that many of us struggle, and I'd like to hear our cardiologist's thoughts about when to pull the trigger and operate on an anomalous coronary artery in an adult. Obviously, the anatomic abnormality was there since conception or birth at least, and here we are now 2, 3, 4, 5, 6 decades later, and we think it needs to be surgically corrected. So what changes from age 5 to age 45 that brings these patients to see us? And then how do you make the decision that this lady is going to have an operation and that one's not?
It's a little bit tough to say. I think there are some changes in terms of the growth and the pressure that's exerted by the great vessels. There's some debate about whether it's the interarterial course or the intramural segment that's more important for creating the symptoms. But I think, the interarterial course is generally thought now not to be as important because the PA is such a lower pressure system compared to the aorta that the interarterial aspect of it shouldn't be as important. The intramural segment is, I think, what causes more of the symptoms, especially if you have those high-risk features like the slit-like orifice and the compression that's associated with that. Why it happens later, it's hard to say, but left coronary anomalies are supposed to be more common than the right, but in adults, in my practice at least, I see a lot more anomalous rights coming off of the left than any of the left coming off the other configurations.
I think that collectively have pretty much debunked the notion that the anomalous coronary artery is compressed by passing between the aorta and the pulmonary artery, for the obvious reason that most of blood flow is in diastole, and the pressure in the aorta in diastole is much greater than in the pulmonary artery. So there's really no physical mechanism by which the pulmonary artery can be compressing a coronary artery. I really do think that this is all about the ostium. I even think that the intramural portion is relatively less important, and I think in lots of patients it's unimportant. But those patients that I've done that have had, dramatic symptoms usually have a slit-like orifice where the inner portion or lip of that orifice is thickened, sometimes even fibrotic. And I imagine that as we age, our aortas get a little bit bigger, the circumference increases, and if you think about the stretch of the circumference of the aorta compressing the two layers of the slit-like orifice, and the medial layer being a little more thickened, and now it's stretching a little more, now it becomes more slit-like, especially during exertion, hypertension due to exercise or exertion. Now that aorta dilates a little more, that slit closes down a little bit more. And I think that's how it happens. So I generally will take a triangle of tissue out of there and scrupulously marsupialize that. I never worry about the pulmonary artery. And I think that we cause more harm than good by doing a very long intramural thing. I usually go certainly less than a centimeter. I mean, it's typically, 5, 8, maybe 10 millimeters, rarely more than a centimeter.
Mario.
I think, John, you're right, but I suspect in most of these patients, we just find out because of imaging. I think the majority of those patients are actually asymptomatic, except that they become symptomatic once they know they have a coronary anomaly.
Very true.
That's, and really, when you look at the data in adult, we have essentially no data. Yes, we know for sure that the course between the PA and the aorta doesn't matter, but it does matter for a reason, that course is generally associated with an intramural segment. So it is a marker of intramural segment. That's why I think in the past there was this misconception that there was a compression. No, there is not. A compression is not there, but it's higher up, is within the aorta, as Chris said. Slit-like ostium and other, like the sharp angle from the aorta, they have generally been associated with ischemia, but not very consistently. So we really don't know what causes ischemia. And I suspect often we do correct those anomalies for no reason. Something that has not been mentioned, that however is very important for surgical indication, is when you find, and this is essentially by MRI, that there is ischemia, and in particular there are scars in the territory reserved of that coronary. This is the best reason for me to operate, because you know that that anomaly has caused ischemia. I think the other two important considerations when you have to decide if you bring a patient to the table or not is, first of all, how likely you are going to have a good surgical result without bypass surgery. Bypass surgery is the last resort here, so how likely you are to perform a good anatomical repair. And sometimes it's difficult to predict preoperatively, but if you know you have, like in this case, a long intramural segment, you can fix that. So for me, this is a reason to be more aggressive to surgery. And then the other consideration is the age of the patient. Older patients, first of all, they have higher risk from surgery. It's not the procedure, it's the general trauma from surgery that can take a toll of them. And also they have probably limited physiologic needs. So I think if I find something like that in the 70s, I think it probably has been there forever and no need to fix it. In the 40s is a different story.
Dr. Nicholson, you had a comment, Mario, what type of testing, while he's taking the microphone, what type of testing do you do for this type of patient? Do you do an MRI to assess the ischemia, or what do you do?
It's very difficult.
Stress?
Because everything we know about coronary artery disease, atherosclerotic coronary artery disease, does not apply to those patients. So clearly you're looking for ischemia. One way to look at ischemia, as I say, was to look at indirect sign of ischemia. So if you find fibrosis, if you find necrosis at MRI or with other imaging, that's a good indication that there is ischemia there. And then you do provocative testing, keeping in mind that, again, this is not atherosclerotic coronary artery disease. The mechanism is different. So vasodilators generally do not help here. It's dobutamine, the test that you should use, because this is the type of physiology that bring to ischemia in those patients.
Thank you. Please.
I was going to echo a lot of what was said, so I don't have a whole lot to add, but I asked a question I've asked a number of times. When I was a fellow back in 2002, this was a benign anomaly, an anomalous right. You know, we'd see it on cath, not infrequently, and I remember working with John Douglas and Spencer King, and they pretended like, who cares? And so the data didn't really change, and you know, still ask those guys to this day, have you ever seen someone drop dead, truly drop dead of an anomalous right coronary artery? Like, have you seen someone that's been a resuscitated VFib arrest that had nothing else other than an anomalous right coronary artery? Because to me, somewhere changed in the last 20 years with no data to support it, that all of a sudden this needs to be surgically corrected. And I don't understand, they all course, or from the vast majority of them course between the PA and the aorta, so that's not it. So like, you know, I think they all have a slit-like orifice because that's the only way you can get to the wrong direction where you're going to. So I still, to this day, have never sent a patient for correction of an anomalous right coronary artery, and I hope to never send one because I don't buy it. And so, like, I just want to hear somebody tell me somebody that dropped dead of this, and I just have never seen it or never heard of it.
So,
Recently came across a similar scenario where a patient presented to our institution with cardiac arrest, was resuscitated.
And only had this.
Taken to cath lab, the only finding was the
Wow.
Yeah, I mean, there are autopsy series which demonstrate that among people who drop dead, the incidence of anomalous right coronary is much greater than is believed to be in the general population. So that's an indirect implication, but it's certainly not a direct implication.
As a surgeon, I must admit that as a young surgeon at least, I always try to shy away from these cases. And probably it's surgical confidence, I don't know. Recently, the last case I had, I just asked to prove me that there was ischemia of the end. I remember it was a phone call Friday night, 7 p.m., and the patient had met a young patient with chest pain, and they did a CT. The CT showed the picture, not even a cath, just send me, transfer over for emergent surgery. And you say, like, it's not going to work like this, you know. I'm like St. Thomas. I have to put my finger in Jesus Christ's wound before I bring it to the table. And unfortunately, I never seen more of a patient from that referring cardiologist, so I must have pissed off someone. But I try not to bring them to the operating room if I can, and I try to, you really have to convince me to do it.
But I have done probably, 30 of these in my career. And I will say that they have all been symptomatic. And I would say about 80, maybe 90% have been relieved of their symptoms. But occasionally, I think what we prove is that the symptoms were not from that thing. And those that have been relieved, I think, are most dramatic symptoms and the most dramatic relief are those that have the slit-like orifice I described with thickening and even fibrosis or calcification of that medial lip of that slit. And they're always in their 40s or 50s. Dr. Servais.
Yeah, we had in 2 cases done pressure wire during exercise on the table of the cath lab with a Swan-Ganz in the pulmonary artery.
Wow.
So I said that will be the solution. If there is something at the ostium, we will detect it. And if it's something during exercise by compression of the pulmonary artery, we have the Swan-Ganz to take the pressure. But it was in 2 cases inconclusive.
Inconclusive.
But I thought that it's still the way to prove something at the ostium or by compression.
So do you think that the single photon counting CAT scanners with the latest generation of FFR might actually be able to document the anatomy and even the functional significance of the so-called slit-like orifice? Is that coming? Are we going to have this as one of the modalities to lean on in this decision?
Yeah. What's going to happen with the photocounting and the FFRCT is that you have to rewrite the whole chapter, because what the photocounting does very well is eliminate the blooming effect of the calcium. So basically your finite element is much more precise. And I'm sure that if you compare conventional versus photocounting, there will be difference in these. The resolution is 111 micron. That's the best. It's superior to the angiography. So you can expect some better result. But I don't think it will help in that field. Maybe on the osteum.
It's very interesting. So thank you so much. I think that this is conclude this session, this true session. We have a coffee break, and please visit the exhibit of our sponsor partner that we thanks.